Good afternoon. Well, let me first thank the organizers for suggesting that I make this presentation about communicating with families. I'm a sociologist. I work within Famille with Elia Zoulé, whom you heard this morning, and I prepared this presentation with my colleague Marine Gest, who's a psychologist who also works within the Famille group. So communicating better with families is, of course, an important topic. We're going to be talking about what exactly communication is, first of all. Well, all the things that happen when two individuals interact. Some people say that it's impossible not to communicate. Even when you don't say anything, you're still saying something. Even when you don't do anything, you're still communicating something. And so any interaction between human beings involves communication. And this is something which takes place in the context of a relationship, which can have different characteristics. If it's a poor relationship or perceived as such, then the content of the information might be rejected and deformed or ignored, which is a very important thing. Information and communication is what we're talking about. Information being the content of the message, what needs to come across to be put through. To communicate is indispensable in intensive care, insofar as it helps the families to make sense of what is happening, the disease of the patient, the techniques used, the feelings they have for the period following intensive care, and sometimes trying to come to grips with the death of the patient. Communication is always part of a specific context, and here we're talking about an asymmetric situation. On the one hand, the physician who is at work in a professional situation and has the information, and on the other hand, the family members who are in a very emotional situation, a purely emotional situation in a sense, and who are hoping for information. A lot of asymmetry then. So what is communication? Well, to unroll this definition further, it's about using words. We saw that this morning with Elia Zoulé. It's also about non-verbal things, posture, attitude, faces, gestures, which have a great deal of importance. Look at the way that a doctor can walk in as part of a round with different attitudes, holding back, very much present in the future, or thinking about it, but or just going in first and then figuring that you'll think about it later. I'm going to go in, but it's a battle I've already lost. Some other examples which may be less directly suited to the context that we're talking about here, but the kinds of attitude that you might take as part of an interview. Are you presenting yourself as an all knowledgeable wise man? What kind of attitude are you going to adopt? This will have a great impact on the way the message gets through. And if you're in a room where there are no tables, sitting in a circle, the position of your legs, of your feet, reveals a great deal about what your feelings are as a physician or a nurse, and the families will note this. So there's the verbal dimension, the non-verbal dimension, and also the paraverbal dimension, intonation, pace. If you talk very quickly indeed, or if you take the time you need to talk about important things. And then there's silence, which expresses things also and can be difficult to manage when you're not used to it, but it's very important if you want to make space for listening to others. Specialists of communication point out that when you want to get a message through, 7% of it takes the form of words, 38% tone of voice, and 55% non-verbal aspects. And you can see at the bottom the degree of control that you have over these things. A lot for words and not so much for voice, and even less for the non-verbal dimension. It's important to bear this in mind when you reflect upon your own attitudes, and perhaps to communicate within teams to get some positive criticism, positive feedback, useful feedback about how you're doing. So communication can be a form of healing. It can be a form of therapy, but it has to respect certain rules. There has to be a fit between the verbal and non-verbal message. You have to be careful about all the things we just mentioned. Make sure that you are listening carefully, and that's all part of effective communication. So why make efforts to communicate better in an ICU? Well, it's a very special universe for families. You know, when they're given a chance to speak, they often say that it's like a world unto itself. It's very different from anything else. You know, a life is at stake. Sometimes the families, initially at least, have difficulty recognizing the patient in the hospital bed. There's a lot of you know, symbolic violence with the highly technical and the invasive techniques which are used, the lack of intimacy. All of this has consequences for the psychology of the family members. Very often, 73% suffer from anxiety, 35% from depression, and then, you know, there's a lot of losing your bearings, of being afraid, of feeling guilty, as Elia Zoulé was describing also this morning. So we're talking about people who are very vulnerable indeed and who really need to understand what's going on. So when as physicians or nurses you organize a meeting to give some bad news or to take stock of where things stand after, say, 3 days of treatment, you may have many things on your mind. You may have looked at the x-rays, the other examination results. You might have prescribed the medication, given instructions to the nurses, planned some tests and examinations, many different things that you have to juggle at high speed, whereas the family member is in a completely different state of mind. For them, the only real question is, how is my relative doing? Are they going to be able to pull through? So it's a very different time frame. You know, the very quick-paced, fast-paced time context of the practitioners, and a much slower time frame for family members. You have to try to be respectful in the face of that. And you may note that sometimes you provide 1 or 2 items of information. Sometimes you find that the family member isn't really connecting anymore to what you're saying because it's such a shock for them to digest what you've just said. And very often the best way to reconnect with them is through verbalization of emotions and empathy. Very often family members misunderstand the information. About half of them do. And of course that has consequences for their ability to adapt to what is happening, managing, for example, the hope dimension, taking part in decision making, and also in how they will feel, how comfortable they will feel during the time that the patient spends at the ICU, and also during the following months, you know, whether the patient has survived or potentially after the patient has died. So, you know, I was talking about a therapy dimension of communication that it can make you feel better during the stay. Many studies have shown that when you improve communication, you can reduce anxiety and depression. And we know that there has to be a reference practitioner, that you have to choose your words carefully when informing the families and give them some very practical guidelines, landmarks that they can cling to, give them the right level of hope, and have enough empathy and active listening to give them time to think also. And you have to improve communication so that they can take a part in decision making. There has to be a fit between the role that they wish to play and their real role in the situation. Otherwise, this can be a source of stress. Subsequently, it's important for the family members to be recognized as full-fledged players and not just as recipients of information. It's also important to give them opportunities to express themselves, because this will also lower the stress level. So during the meetings with family members, a number of studies have shown just how important all these dimensions can be. Seymour in the UK has highlighted the role of the teams in shaping the expectations of families. This has a lot of impact on the way that the family members experience things. How do you prepare the ground or bring things up? And then Slomka and Timmermans have worked and shown just how important it is for the caregivers to elaborate the meaning of what is being done. For example, CPR is something which can be experienced by the families depending on how you present it as one final straw of hope, a final glimmer of hope in the face of death, or as something which is very aggressive, being put on a respirator, can be seen as extending life or as drawing out the process of dying, depending on how it's presented. So this is all about communication. It's a two-way process. It's not just about the caregivers providing information to family members. It's a collaborative process. And then the quality of communication during the patient's stay will have an impact on the experience of the family members after the end of ICU care, no matter what its cause might be. 3 months after the patient leaves the hospital, a third of the family members have post-traumatic stress symptoms. And among the predictive factors, the ones that are highlighted here were very important, as you can see. And these heighten the likelihood for the family of presenting with stress symptoms. Famille was able to show in a multicentric center about the end-of-life period that many of the family members saw their grieving complicated, aggravated by various factors, one of which was unsatisfactory communication with the medical practitioners, which can complicate the grieving process up to 6 months after the death of the patient. What do we hear from the families? Some of the interviews we carried out. As part of our studies, the daughter of a patient said the doctor was like God, but without the ability to listen or to be generous. The son of a patient said, I've talked with the doctor for 3 years. He was all about talking about all the science, all the scientific knowledge he'd accumulated. He was like talking to a brick wall and incapable of hearing anything I wanted to say. And a longer piece of testimony from the patient's daughter saying, I saw 3 doctors in 2 days. I didn't like the last one. He asked us 10 times, do you understand the situation, as if we were idiots? And he kept saying, do you understand? And it was systematic. But I guess, it's not so much that they consider us as idiots as that it's part of the protocol. Perhaps the protocol needs to be rethought, thought about afresh so that they can adapt to our needs. And that is something I think that, the families really feel the need for, namely for the teams to adapt to their needs. So we do have tools that can enable us to communicate better in an ICU. The booklet, which is given to the families when they arrive in 2 groups here, one which did and one which did not get this booklet. And you can see there were much fewer difficulties in understanding. You can see the percentages at the bottom here. It's not just, of course, about handing out a little booklet or a brochure. It's also about the interaction, focusing on this piece of documentation and the kinds of relationship that can be built on that basis. Randall Curtis has also highlighted other tools at the meeting to mark the final stages of the patient's life, where you have to uphold this mnemotechnic of value, to acknowledge, to listen, and understand, elicit questions from the family, and of course value all of this. The benefits for the families have been highlighted by many different studies: better understanding and satisfaction, ability to be recognized as full-fledged players and personally recognized, given the opportunity to speak up during the meetings, and thus an opportunity for the practitioner to listen, and less of a feeling that the patient is at risk of being abandoned or of suffering, because that can be a major concern. Famille also enabled us to organize such an end-of-life meeting with the booklet that was handed out, and we were able to greatly lower anxiety, depression, post-traumatic stress symptoms. So we have tools that we need to make proper use of, but there are practical problems we have to overcome as well. There are these defense mechanisms. Of course, I'm not a psychologist myself, but psychologists are well able to describe these defensive mechanisms whereby the subconscious draws up obstacles to protect the notion of self of the patient, of the family member, and these can be very powerful mechanisms. So that I'm sure all of you have seen, defensive mechanisms like being stupefied, denial, trying to take control, displacement, aggressive projection, and so forth. And you've also similarly seen your own colleagues, or indeed yourselves, responding with defense mechanisms during these sometimes difficult meetings, rationalization, putting off decisions till later, projective identification, or just laughing it all off. This is, of course, something which, if we can recognize it, and provides us with an opportunity to adapt to a situation that does generate anxiety, explore the emotional dimension of things, and develop relational skills. There is no ready-made solution for these challenges. Randall Curtis had recorded meetings between doctors and family members, and he talked about the missed opportunities that could be noted, where it can be possible to answer specific questions, to recognize emotions, a sense of guilt, and to deal with these things. And of course, the caregivers are entitled to have emotions too. Sometimes the family members can, be touched to see that the caregiver is struck by sadness or disappointment or other emotions. And it's important to hear these things, to recognize them, and try to work with them. Practical problems also can take other forms. Many families, and many of the studies that have been carried out say similar things to this. A patient's wife, this is about the number of players involved. I just couldn't bring myself to cry because there were too many of them. There were too many of them, and I was too alone to be able to cry. The son of a patient who said, I felt as if, they always felt this need to come in as a group to give us the bad news so that everything would go all right. It's not human, it's professional, and that's the way it always is. I've never been able to talk one-on-one with any single practitioner as if I was going to take them to court if they made any mistakes, as if the others were there to bear witness, and the others don't speak, so why are they all there? It's very difficult to strike a proper balance there. And of course the coordination teams for organ grafts and removal of organs try to give a lot of thought to this. In the university hospital, you also have the trainees who are learning the job. It's very important, perhaps, to make sure that everyone can introduce themselves. The doctor, and then say, rather than to say, "I'm the doctor and this is the nurse." Each person can introduce themselves, and that makes it more meaningful for the families. It's not necessarily always, the case that everyone has to say something. You can simply, touch the arm of a family member or go and get them a glass of water, whatever the case may be. There are also cultural dimensions that have to be taken into account with the diverse societies that we live in. around us. People may have different perceptions of health, different spiritual or religious beliefs. Of course, we can't expect caregivers to know everything about everything, but it is important to have some basic understanding about whether different people might relate to death, in the notion of death in different cultures. And some American universities try to highlight this notion of diversity. There's also the non-verbal dimension, where you have a linguistic barrier. Depending on the country you're in, a gesture like this one might mean very different things, as you can see on the screen. So one final idea in this vein is that you have to have a culture of service. There's an atmosphere which has a lot of impact on the caregivers, on the patients, and on their families. All of these players talk about the effect of the atmosphere on what happens in the service and the way the communication with family members takes place. Therefore, it's very important to ensure that you're also able to provide for good communication within the team if you want it to be able in turn to communicate better with the family members. So a holistic approach is called for, where everyone has something to contribute to this overall puzzle of communication, which is a complicated one. In conclusion, we can indeed communicate better with families in an ICU where priority is given to paying attention to what others have to say or to communicate. This is something that can be improved through training with various learning materials. You can also hand out booklets and use these as tools. Use gestures and body language to ensure that the family members will feel better throughout the stay of the patient and after they leave the hospital. Thank you for your attention.